So Rose, have you got a count of board members online? We have enough to start.
My count is 7.
7?
Mm-hmm.
Okay,
Yes.
thank you. We have a quorum then. So I know Reed's going to be a little bit late, but she will be joining us. And so with that said, I will call to order the March 2nd meeting of the Oregon Educators Benefit Board held by Microsoft Teams. And the first order of business, as always, is to approve the meeting minutes from the February 2nd meeting. We got any questions on that, or can we move to approve?
This is JJ. I move to approve.
I'll second.
Thank you, Bonnie and JJ. All in favor?
Aye.
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 This is Tom. I've joined the group.
Great.
Aye. Robert, too.
I'll have to remember to do that presumptive acceptance. Just ask for those that oppose. Seems more efficient on these kinds of calls. Okay. First up is Glenn Daly with legislative update, and we've got a fairly good sized handout, which is good, I think. Go to it, Glenn.
Yeah, I wanted to provide, it's March 1st, a legislative update. I don't know with the legislature whether this is the Ides of March, but they will be busy. First of all, just some basics of the session and some of the timing. Excuse me. It applies for, it's going till March 27th, and that's when they have what's called constitutional sine die, and then they have the target sine die, which is March 21st. So the second thing too is March 19th is the final day when they can post a work session. So that means they have to schedule a work session within that time frame. Usually they have to have all of their public hearings by then. But sometimes, especially on the Senate side, they will do work sessions and public sessions at the same time. The next one deadline, which is April 13th, excuse me, is when they have to have basically voted it out. I mean, they can't go beyond that. So that means that the next couple of weeks are going to be extremely busy for both doing bill analysis that we do here, as well as fiscal impact statements. After that, it goes over, it'll either go toward the next policy committee in the second chamber, or it can go into rules, ways and means, or finance and revenue. If it goes there, it can live till the end of the session. So anything with a price tag is going to go to ways and means. What I wanted to go over, first of all, is just really our priority bills, ones that are directly affecting PEB policies or programs. The first one is actually a repeat bill that came from the previous session. This is Senate Bill 551 and House Bill 307. It provides that part-time faculty members at public institutions, community colleges, universities, who qualify for our HB 2557 program will now only pay 10% instead of doing a full 100% self-pay. The rest of it will be paid by the state. This has a very significant, and if you look in the appendix, it has a very large price tag. Much of it comes from the general funds that OEB would need to have appropriated to them so that we could pay that 90%, which is Willis Towers Watson estimated it at around $7 million per year. Senate Bill 12, this is a bill that it requires that OEB and PEB provide a program that allows members for certain drugs to travel to hospitals or drugstores in Mexico, especially Tijuana, or in Vancouver, Canada, to fill their prescriptions and refill them. There are certain limits on it. You can only do a 90-day supply. You can only do it once at a time. You can't do, go and get a whole bunch of drugs at the same time. This has no public hearings scheduled. There are a lot of issues with this bill. One is we had our consultants run it to find out based on, it's based on a program in Utah. So we use their the drugs that they have for their program, and along with their utilization, and found that we would only save about $500,000 a year. And that's on a specialty drug bill that's 70 million per year. The other problem, it stretches the concept of personal use that the FDA has. The FDA really doesn't, allow for or did not consider these kind of facilitation programs on there. The second is the drugs, the payment for travel, the payment for, the lodging, most likely would not get tax exempt status, which would require that taxes would have to be placed on those, which would be it would have a financial impact on the member, on the employers. It would also have a really big administrative impact on PEB and OEB too, to try and, we don't have access to all the payroll systems, especially on the OEB side. Senate Bill 650 creates a public assistance protection fund, which is funded through an assessment on employers with a certain amount of employees. It goes to different programs here at the state. And one of the ones that they cited was where 25% of the funds would go to PEB to offset school district unfunded pension liability. This is most likely a drafting error, and we sent to our government relations folks and said, we have nothing, PEB has nothing to do with school districts or unfunded pension liability. And OEB also would not have that data and that information. 2317, it adds 2 new non-voting legislative members to the OEB board. There's really no fiscal impact to that bill, but no public hearing has been scheduled. And stop me as I go along if you want more information or you have questions about these bills.
Yeah.
House
Glenn,
Bill 2810 requires PEB and OEB to really establish what I call CCO-like plans or Kaiser-like plans in 2023 that every one of its carriers are going to offer. And then in 2026, all the plans offered by the carriers would have to meet they have global budgets, value-based payments, joint risk sharing, very much CCO-like, or even, kind of almost modeled on Kaiser. There have been a number of meetings, and Ali has gone to those with Representative Dexter, who is running this bill, and other stakeholders. I believe, and Ali can correct me if I'm wrong, that the goal would be to do now more of a regional pilot, but there's been no public hearing scheduled, and no, I have not seen any amendments to this bill. So we're not really really sure of the status on that.
Yeah, I think the meetings are continuing. Jeff Brown is in those as well, and I think pretty much every stakeholder group imaginable for PEB and OEB are also participating in those meetings. And I think now they're looking at a regional pilot, and there obviously would be significant member disruption, potential costs and potential other issues that they want to discuss and work through. So we're participating in that. And Glenn, I want to make sure JJ had a question earlier. JJ, you want to go ahead?
Yeah, I was just had a question. I don't even know if you would know the answer, Glenn, but the bill on buying prescription drugs in Canada or Mexico, have you heard whether there is a potential constitutionality issue with that as it relates to interstate travel of controlled substance?
I have not, and I can also get back to our attorney at the Department of Justice about that. He did review it on a number of other issues, like the FDA regulations. But I can ask him. It's a good point.
Yeah, I mean, the concept of it is, whether we're being overcharged in the United States, can we be undercharged in another country? And $500,000 isn't a lot of money as it relates to a $60 million budget. Still $500,000. But I was concerned that it may run into some issues with the drug and alcohol enforcement of interstate travel of controlled substances. So that's all I got.
Okay.
Glenn,
Thank you. Yes.
who's sponsoring 2317?
And why?
Let me just double check real quickly. I believe it might be Salinas. Hold on just a quick sec.
It is Rep. Salinas,
Okay.
and I think it was pushed out by OSBA.
Yeah, it is Representative Salinas.
Okay. Thank you.
So next one is, well, there are actually two. They're different versions of kind of the same principle. House Bill 3044 and House Bill 3094 requires that PEB and OEB only contract with carriers who sign a compact or other form of voluntary agreement committing to using value-based payment methodologies in 70% of all our carriers by 2024. 3094 says it's the same thing about contracting with those who sign the agreement, but in the agreement committing to taking steps to achieve a target percentage. It doesn't set the target as the first one does. These, to say, we of course put in a number, we said it was indeterminate, but we did say that there are a number of problems with these bills. One would be it would limit the board's contracting authority because it would require that these contracts only be provided to those who sign this OHA agreement. Second of all, if one of our, especially extremely our large carriers pulled out, said we're not going to sign the agreement, we couldn't continue working with them, and that would mean if the board feels that we can't fill that gap, then we're going to have to go out for an RFP, and those usually take around 36 months to put out and to implement. So there is that, and then just large patient disruption on that. So, they haven't moved. They haven't gotten a public hearing. It's Rep. Prusak is the sponsor. She is the chair of the healthcare committee. So I don't know what the status, where those are headed.
Well, and this is Ollie. I believe Jeremy's going to talk about the compact this afternoon. And I think it's kind of a moot point because I believe all the major carriers for PEB and OEB have signed the compact. He can verify that, though.
Yeah. Oh, that's good.
Mhm.
House Bill 2010, that recently came up. That was, it creates a public option within the marketplace. It has a number of elements to it. It requires that, the providers are only paid 100% of Medicare. It wants the plans to use value-based payments. I won't go into all the details of what it expects of this public option, but this would be a public option within the marketplace. How it affects us is it requires that all those plans, carriers who are contracting with OEBB and PEB have to offer a public option based on the requirements of the bill. And second of all, it says all providers who are in a OEBB or PEB plan then can't refuse to participate in a public option plan. So it really, I haven't completed the bill analysis on that, but it has many of the same problems that the 3044 and 3094 have on that. My understanding is there's going to be some amendments to that bill. It's Representative Salinas is sponsoring the bill, and Osberg is one of the big proponents behind it. But again, no public hearings have been scheduled on that.
Okay.
Those are all the priority ones. I'm happy to answer any other questions. I tried to put in the appendix, kind of our analysis of the bill, what the potential issues are, and what fiscal impact we have at this time.
Great. Any final questions for Glenn? All right, thank you, sir. Next up are COVID updates, starting with Kaiser. I don't think we have any visuals for this.
Great. Well, we have with us today Sapari Sturdivant, who you all know, as well as Jennifer Stacy, who has also worked with OEBB for a long time and has really been leading lots of efforts related to vaccination with our for our employer groups, including OEBB and PEB and other groups, and she's been a great job with that. With that, Sapari, would you like to kick this off?
Yeah, thank you, Dr. Bachman. Sorry, I had lost, I was talking, but you couldn't hear me. So thank you for having us today, Jeff. We will have the agenda for you today. I know it's going to be brief. We only have 10 minutes, but we'll have Dr. Bachman talk about the clinical updates, and Jennifer Stacy is also here with us to give you updates on the vaccine clinics, and all things vaccines. And then I'll close it up with kind of some member communication materials. So with that, Dr. Bachman, do you want to kick off the clinical updates and
absolutely
also?
Absolutely. Just want to acknowledge that February 28th, just last week, was really the 1-year anniversary of the first documented case of COVID-19 pneumonia in Oregon, and that was treated at our Westside Medical Center. And there was really a great discussion of that, I think KGW had a really nice article with some of the physicians and the nurses and other impacts that this OEB member had experienced and how the world has changed over the past year. Surgical good news is that as of March 1st, our surgical services are really being back up to normal, with all operating rooms being open and even some with extended hours, and the elective cases are ongoing and being scheduled, and we're really seeing the volumes go back up to pre-COVID level, and our surgical backlogs have been markedly reduced or are really nil at this point in most of our surgical specialties. Our testing program continues to be ongoing and successful with several sites for COVID testing. Our lab turnaround time has really been pretty amazing, with a typical average lab turnaround time over the last several weeks of 16 hours or less. We still tell people to expect 2 to 3 days, just in case they are traveling and if there is a delay or a breakdown at the lab. But really, over the last several weeks, the turnaround time has been great. As you know, the most effective test is a test that is both accurate and gets information back to the exposed individual or symptomatic individual as quickly as possible. I'll say a few words about vaccines and then turn it over to Jennifer for a little bit more. So certainly the question of the week I've been getting in clinic is, when can I get my vaccine and which vaccine should I get? And really the answer to this is as soon as possible. For the first part of that, we certainly know the sooner we can get people vaccinated, we're in a really good spot in Oregon right now, the sooner everybody can get as quickly as we can push the vaccinations out, the better off we're going to be at avoiding problems with the vaccine variants and really being able to minimize the impact and the duration of this pandemic. Second part of that question is, which vaccine should I get? And I think we're in alignment with the CDC and other experts that the best vaccine is the first one that's offered to you. I know we have the Moderna and the Pfizer vaccine have been out for a while with really, I think there's still potential for reactions, and we know some people do have a significant feel pretty crummy afterwards, but really the severe safety issues have really been fairly minimal or not different than other vaccinations, the kind of reactions of anaphylaxis that ends up people in the emergency room and really very rarely hospitalized. So that really, I think, was a bigger fear at the beginning of this new vaccination, but now that we've been doing so many, I'm really seeing how quite rare that kind of reaction is. I still do talk to people after their first or second vaccine that have a very sore arm or feel pretty crummy, and you may have fevers for a day or so, but that's usually handled over the phone, and we're not seeing any real severe vaccine reactions. And people say, well, which vaccine should I get? And it's the one that's most available to you. We're really pleased that the Johnson vaccine has been approved and is now shipping around the country. That is an amazing vaccine because it only requires one dose, so it has quicker to get full efficacy. And we know for all three of the vaccines, they're all amazing at preventing the serious complications of COVID that would require hospitalization or death. Essentially, there's been no hospitalizations or death in anyone who received any of the three vaccines that have been approved so far. We are, in terms of equity, we are very concerned about that. We're following our data carefully to make sure that we can deploy vaccines in the highest risk population with the most rational approach to that. We've awarded 2 grants of $150,000 each, one to the Oregon Latino Health Coalition and one to the Oregon Pacific Islander Coalition. On March 13th in Salem, we'll be having a event for the Pacific Islander population that qualifies for vaccinations. And we know that population has been affected about 3 times the rate of a white population and want to get those vaccines out. So we're excited to be able to offer that through the Pacific Islander Coalition with the event in Salem on March 13th. We are beginning programs to offer home vaccinations for our homebound members via affiliation with Metro West. And so working on the logistics of that. And we're also very excited that we've been approved to offer vaccinations within our pharmacy system, which will, again, once that's fully rolled out, will offer more places for our members or potentially non-members to get vaccinated. With that, I'll turn this over to Jennifer.
Hi, Jeff, I see you have a question.
Yeah, and I'm been multitasking, so I'm sorry if you already answered this, but any of your clinics have more capacity than others? Part B to that is, how are you managing to keep the balance going in availability of the vaccine?
I think I'll let Jennifer take that.
Yeah.
I think that's
Yeah.
what she was on top.
Yeah, so just a little bit of information overall, and I'll address your question, Jeff. To date, we've had about 141,000 of our members and non-members being vaccinated. Members inside the OCC, the non-members are counted differently. There's a bit of a delay in data, so it's always a bit of a lag as far as Oregon up to 10 days, and Washington we only get it every 30 days. But of those 141, over 13,000 of them have been OEB members. We've got almost 5,000 fully vaccinated with their prime and booster shots, and then another 42, almost 4,300 who have their prime dose, and we are scheduling second dose at the same time, so they should be scheduled out for the next one. As far as what is available, we've had the majority of the vaccine being allocated towards the Oregon Convention Center, and we have reconfigured that. So you might have heard that it was closed on Sunday and Monday, just yesterday. We're moving from the Oregon Ballroom we moved from the Oregon Ballroom into the exhibit halls with the intent of increasing that throughput, as well as being easier for seniors and others with mobility issues to navigate. So it's a shorter move through the Oregon Convention Center for vaccination. We also had efficiency experts and all of that look at it so that we would be able to not have bottlenecks at any portion of the process.
Okay.
The scheduling for phase 1A, so I know the OHA representative may speak about this, but the phase 1A and the seniors has changed for the Oregon Healthcare Authority. The educators continue to use the chat bot, and all phases of education, all phases of the educators are open for eligibility. You asked about other areas. Southwest Washington, which I know the majority of your folks live in Oregon, but we do have some folks that commute. That has been extremely limited in Clark County overall. However, this week we are supposed to see increased supply. Salem and Lane County as well, we are continuing to vaccinate out of our medical offices as as supply arrives, but I would say none of them have excess capacity that people would, be able to always get a space at any of the locations, including the convention center. Did that answer your question, Jeff?
Yeah, thank you.
And I see someone else has their hand up.
JJ.
JJ.
Yeah, I have a question about your communication plan. I know in Southern Oregon, we have had a challenge, which is getting the word out to folks, and we're moving away from max vax scenarios to more primary care physician and pharmacies providing the vaccinations. But the challenge is how to communicate with those who are currently eligible to let them know the methodology that they're going to go about to get that. And in our local area, we're standing up a call center to transition, especially elderly folks who don't have great internet access as a way to communicate that. So can you speak to what Kaiser's communication plan is to get the word out to membership on what their options are?
Yeah, so we have been communicating regularly to our membership, primarily electronically, to your point, in that we have weekly updates to the membership. We also have recorded lines for them to call in. We have information on the websites. As the supply builds and we have it changes in eligibility, so chronic conditions and different pieces like that, we've worked through we will build the communication plan for those specific individuals. As Dr. Bachman mentioned, we are working on the homebound individuals. So it's really like a combo. We recently sent out mailings to some folks that had signed up for eligibility information that only had address and not electronic capabilities. So as the supply builds, we will evolve it. Right now, there are so many people going for so few vaccines that we also, we're trying to kind of balance that. One thing we do think will help, which Dr. Bachman mentioned, that the KP pharmacies have been approved for the federal pharmacy program, and that will allow us to receive more supply to be distributed out of our locations that have pharmacies. Not that it'll be every location. We're working to figure out what those plans will look like and which locations will be used for vaccination clinics. And we'll have a specific eye towards vulnerable populations and equity, and work to make sure that we are vaccinating those and getting the word out through various, whether it's community partners directly to the membership, et cetera. And then we, of course, continue to partner with the OHA. So with the Get Vaccinated Oregon, folks are signing up and will be pulled from randomly. And then the Oregon Convention Center call center is reaching out to schedule those folks.
All right, thank you. We'll move on to Moda.
Good afternoon, Robin Singh from Moda. Update on COVID-19. So overall, COVID-19 cases have been declining globally, nationally, and within most US states for the last couple of weeks, though the last few days are seeing evidence of that leveling off in some countries and some of our US states, and in fact continuing to rise in others. Similarly, in Oregon, we've observed a significant decline in cases for the last couple of weeks. This is likely due to a combination of growing immunity from vaccines, prior infection, as well as testing and isolation and general preventative measures. There could also be other factors that are under investigation. Despite this, the virus continues to mutate, and these variant strains are being observed all over the world, including some that have likely originated within the US. Looking at case numbers, globally, we have over 110 million cases and around 2.5 million deaths. Nationally, over 28 million cases, that's almost a third of the world, with over 500,000 deaths. In Oregon, approximately 155,000 cases with 2,200 deaths. OHA reported a 7-day moving average of around 400 a day, and yesterday there were 6 deaths. For Oregon, most counties are still deemed extreme or high risk, and precautions should continue. In terms of vaccinations, in Oregon, close to 1 million doses have been administered to around 650,000 people, which is a similar percentage to the national average. We've completed the earlier phases of vaccination and moved this week to all persons aged 65 years and over. Around June 1, we're expected to move to the much larger population of those over 45 years. So far, the UK strain B.1.1.7 has been reported in Oregon. Brazilian and South African strains have not. There may be other strains present that we're not necessarily sequencing for. Looking at the OEBB data breakdown, active test member count, 22,700 approximately. The active test count, about 31,000. Antibody test count is about 1,700. The case count, and so this is all year to date, approximately. Case count for hospitalization is 1624, ER count 154. The total case count is 1624, the ER count is 154, and the hospitalization has been 49, with ICU at 19, and the fatality count at 5. COVID-19 vaccinations, so vaccinated member count, 1,233, of around 1,000 have received both doses, therefore fully protected to the extent possible, and that's for Pfizer. For Moderna, the vaccinated member count is 3,800, and around 600 have received both doses. The amount spent was 152,900 in total for both vaccines. The average cost per vaccine was $30.29. Testing costs have been around $3.3 million, and treatment costs have been about $4 million, and that represents our membership of just under 100,000. There is likely underreporting due to reasons discussed previously, and there is a delay in this data as well. I see a hand.
Yeah,
Is there a question?
Yeah, this is Tom. The question I have has to do with what percentage of OEB members, I'm saying subscribers, not members, I should say. Do we have a sense of how many, what percentage have been vaccinated? The goal of moving educators was to be able to open up schools. So I'm interested in seeing what the effect of that was. Are we in the 10%, 50%, 90% range?
So we're looking at eyeballing these figures, and we can provide you with more specifics subsequently. This is about 5,000 I'm seeing there. Out of a membership of about 100 is suggesting just at about 5%. Now this data is a couple of weeks old at least, then there's delays in when it actually has been collected. And as you know, vaccine, the level of vaccination is rapidly accelerating day by day. So we're probably quite a lot higher than that, but it's looking like between 5 and 10% roughly, and we can certainly follow up with a more accurate number.
Yeah. If we can track that over time, I think it would be very important. I mean, my hope is that we get in a month, we're able to get to it being 80%.
Great. Yeah. Thank you. We'll do that, and the data collected does answer that question. So in effect, we're tracking it, and we can certainly report on that figure consistently, if that's helpful.
So Tom, I think the denominator is going to be different because the only people in OEB generally that can get the vaccine are the educators, not any of their dependents. So I think we need
I understand that. That's the reason I said subscribers.
Right.
Okay.
In
Thank
terms
you,
of
Doug. Go ahead.
Just have a few more items if that's helpful. In terms of treatments, only remdesivir, an antiviral, has been fully approved for the treatment of COVID-19. The expert US panel develops NIH treatment guidelines, and there are a number of other drugs that have received emergency use authorization, and there are also existing drugs used for the treatment of COVID-19 in small subsets of patients, typically in the inpatient setting. Given, however, that there are limited proven therapeutic options against SARS-CoV-2 for most affected cases, the mainstay for prevention of further deaths is continued protective safety measures, testing and isolation, and vaccines. Pfizer and Moderna vaccine rollouts continue. A new authorization was obtained for Johnson & Johnson's single-dose vaccine, which should reach Oregon this week for distribution. This will help us to reach the goal quicker of 300 million vaccinations. This vaccine uses a harmless adenovirus to carry the SARS-CoV-2 spike protein, unlike Pfizer and Moderna, which utilize the mRNA technology. The Johnson & Johnson vaccine is reporting 72% effectiveness in the US. The rates are different in different parts of the world because of the strains that were present during this data collection. And of course, this only needs standard refrigeration. The biggest concern now is new variants from the UK, South Africa, Brazil, and several new strains detected within the US, for example, Southern California. Higher transmissibility, hospitalization, and deaths have been reported from some strains. There is concern of reduced effectiveness from existing vaccines to some strains, leading to vaccine manufacturers to consider working on new versions of the vaccines that will be more effective against multiple strains. That being said, these vaccines are still highly effective most of the time and life-saving. A UK study published last week showed for the Pfizer vaccine that the risk of being infected was reduced by 70% after a single dose and by 85% after the second dose. Overall hospitalization and death was reduced by 75% after a single dose. A variant over there of concern was the Kent variant, which is spreading rapidly. The Pfizer vaccine remained highly effective against that strain. So that's really excellent data. The overall goal here is to reduce death rates by vaccinating everyone and also to reach herd immunity, protecting those who do not have access to vaccines most of the world, or not receiving them at the same rate. Significant racial disparities exist, those in whom it is contraindicated, and children, amongst others. Of course, herd immunity may also bring an end to the pandemic for everyone, though there is now concern that the virus may persist at low levels in society for the longer term. Thank you.
Great, thanks, Dr. Singh. I just want to provide just a brief update on benefits and communications. We recently sent out a brochure or a flyer to all of our OEB members about the safety of the vaccine, and did a really great visual on how the vaccine was developed compared to how vaccines are normally developed. Really just trying to get the trying to communicate that the vaccines that are out there today are safe. We've also posted that on our OEB specific COVID site. So we have a site that is specific just to OEB that includes all of the COVID information that we have at the moment. So it will include the benefits around COVID for members, and then also other information that we want to communicate to our members about COVID. And that is it. Any questions for Moda? JJ?
Yeah, you answered part of it, Ashley. You can read my mind, I think. My question is about vaccine hesitancy. I know in Southern Oregon, we are some of the lowest level of vaccination in the entire country, much to my chagrin. So can you talk, if you've done any work with working with different entities on having conversations with their employees who may be vaccine hesitant? I know sending a flyer out, I think will have a limited return on investment to someone who already is not interested because they're unlikely to read that flyer. But I think some direct communication at the entity level might be more successful. I was curious if you've done any of that work.
Yeah, so work that we have done is we have utilized our wellness advisors to send some COVID specific information out to our entities, so to the entity level. And I believe that we also sent that COVID flyer to our entities as well. And I will ensure that we did do that. But other than that, that is the level of communication we've had with our entities. But definitely we can reach out and see if entities have any other questions that we can help with.
Thank you.
Okay.
Yeah, JJ, I know Department of Education, we met with them early on, and I know that they were working on some educational materials. I think, labor on our board probably has had some opportunities to do some of that as well.
Yeah, it's a unique skill, just getting people to open their mind and see some value in it. One of our nurses in public health, she's referred to as the vaccine whisperer because she's amazing at communicating with people who are vaccine hesitant and getting them to recognize the genesis of their hesitancy and getting them to change their mind.
Good. Okay. Do we have somebody from the Health Authority? Is it Lisa Bai? Is that how you say her name?
Lisa Bowie, she was pretty iffy. Rose, was she able to confirm with you this morning?
No, she wasn't.
Okay.
So nobody from OHA, sorry.
Okay.
Maybe next time.
It's okay. They're a little busy. We were lucky to get them last meeting, but we'll make sure and get an update from them and send it out.
Okay. Ali, you're kind of somewhat in the loop on some of this. Any changes to the systems that you're aware of?
No, I mean, I think there's more vaccines coming into the distribution system, and I think things tend to change very, very rapidly from day to day, and that's kind of where it's hit or miss with some of our OHA counterparts that are living in this, and but so far, it's my understanding a good part of our OEB population, at least the subscribers eligible, have been vaccinated. But we'll see if we can get a more real-time percentage to the board.
Okay. Well, that puts us back on time. So with that said, Our consultants are up next with our renewal progress.
Thanks, Jeff. So yeah, thanks. That was really sobering information and statistics, I think, to hear not only about COVID in Oregon, but among the OEB population. And then just, Jay, to answer a question or to pile on to the question that you just asked about the communicating the value of the vaccine, we've been seeing some survey data come back that indicates that employees really have, you may not believe this, but they have a pretty high trust level of their employer for disseminating correct information. So when we're working with some of our employer clients, we're really seeing some value in the employer sending out communication about the safety and efficacy of the vaccine. So for what it's worth, just my 2 cents. Okay, so we'll turn now to start talking about the renewal. We're going to do the renewal discussion in 2 different phases today. This first presentation will focus on the medical renewal and some of the options that are being presented. And then Dr. Barrichello will do a little bit of discussion about the new dental plan options. And then we'll sort of come in again and talk more about the dental, vision, and EAP renewals in our round 2 discussion later this afternoon. So Rose, do you want to move forward 1 slide? Or 2, yeah. Sure, so we put together an executive summary of where we are to date so far in the renewal process and our negotiations with the carriers. So on this page, these are all the renewal positions as we have them today, all inclusive of taxes and fees. So this is really representing what members or entities are going to see for the Moda, Kaiser, Delta Dental, Willamette Dental group plans. So we'll talk through each of these with you a bit today and explain what has been updated. Just note that there are some benefit plan changes on the table for the board to consider, which could impact the ending result of these numbers. So on the medical, really, although we are going to talk quite a bit about some of the changes being proposed at the end of the day, if the board approves all of the plan changes, the additional impact to the renewal is just about 0.25%. On the dental, we have a variety in this a little bit later. We'll talk about some of the plan changes, but most of the plan changes we're talking about are benefit enhancements to preventive coverage. And so that'll have the impact of increasing those renewals a bit more because it's a very well utilized plan in some cases, or a benefit in some cases. And then on the vision, you'll see that the renewals are pretty modest for Kaiser and Moda, and VSP is a pretty significant reduction. Okay, so this is where we are starting from. Let's go ahead and go to the next page. Now, Rose, yeah, there you go. So we do need to keep in mind where where the weighted average renewal is against the 3.4% target. Even though each of the renewals are below the 3.4% target, we will be working towards that larger goal as well. So we're in quite a good favorable position at this starting point. A couple of the medical renewals that are being considered: a new Kaiser medical plan, which has a $1,200 deductible. We'll talk a little bit more about that. There's a couple of different pages of optional benefit changes for Moda, which were discussed in CIAO. We'll discuss them a little bit more today. And then on the dental, again, we'll talk about that a little bit later today, but there's a new dental option being proposed and some benefit enhancements for preventive care.
Jenny,
Yes.
you've confused me because for the last couple of years, the taxes and fees, which don't play into the 3.4, you haven't included, because our goal has been to look at what the increases were, and then afterwards the whatever taxes and fees got added were included. This time you're including the changes in taxes and fees, and I don't know whether or not it means we're meeting the 3.4. So I'm confused by your approach.
I think my verbal comments, I kind of moved a little too quickly. On the next slide, we'll talk about where we are with the 3.4% target. But you're right. I think in the past, we've had, one set of renewals with taxes and fees and a separate set of renewals without, because we have two different goals. One is to, just ensure a favorable renewal for OEB members. Then the other one is the legislative 3.4% target, which has just a little bit different calculation methodology. It's important to hit both of them. So what we just talked about are, what are the members going to see? What are the entities going to see? All included with taxes and fees. We go to the next slide. So slide 6, this is where we are against our 3.4% legislative cap. And again, as I just mentioned, that doesn't include taxes and fees. If we go ahead and strip out the effect of the change in taxes and fees for this upcoming year, our weighted average renewal for all of the medical, dental, vision costs combined, we're at 2.95%. So we are also under that 3.4% cap. This doesn't include any assumptions for plan design changes, and we haven't assumed any adoption of benefit changes, which could impact the final number. Does that help answer the question a bit better?
Yes, thank you.
And Tom, this is Ollie. And the executive summary, we asked Willis Towers Watson to start creating an executive summary that our board members can use to communicate to their constituents, and something that's a little bit easier to communicate and to absorb than the entire report.
I'm fine with that emphasis.
Oh, yeah.
That's what the customers see. It's just that it's opposite of what we've done for my previous 4 years. It's always been, how do you meet the 3.4, and then, okay, now this is the real effect. This is what our customers see.
Yeah, you're right. It gets confusing no matter which way you
understand. Yeah, I understand. I'm on board. Thanks.
And just following up with Tom, changing the way we look at it now, this might be the only year that we go this far down. So I would just want to make sure we're consistent going into the future.
One of the things we've been considering is the larger audience is the customers who are going to be paying the bill. So we can always adjust for the government, and it's kind of a litmus test at the end. But we've had a lot of input that what you guys are talking about in the meetings is not what we see. And so we're approaching it a little bit differently this year because it's easier for us to adjust to the state requirement as long as we know we're there. And the school districts can track with our conversations better this way. At least that's the theory.
At least if they know, though, that no matter what, we have to hit the, what our requirements are, because in a way you have to start meeting. You have to be within the confines of the authorizing law, and then you go from there. That's all.
Yeah, agreed. Communicating would be a lot easier if Myers-Briggs only had one box.
Okay, let's go ahead and move on and talk about the individual medical renewals. So for Kaiser, I'll just remind you verbally that the Kaiser renewal as it stands today is a 0.87% increase, so just under a 1% increase. We will get an updated Kaiser renewal calculation to share with you at the next meeting. And so that could change slightly, but that's where we are today. Kaiser isn't proposing any significant changes to the medical plan other than the opportunity to introduce another Kaiser plan at a price point that's in between Plan 2 and Plan 3. I'm not sure what they're going to call it at this point, but so this is a $1,200 deductible plan, and the price point for this is going to be about 4% lower than the $800 deductible plan. And then the high-level benefits are here for you today to look at.
So any questions on that?
I think it's called Plan Marzipan.
Sorry.
Okay. Nothing.
So we did put these yellow puzzle decision points on here to flag that it would be helpful for the board to understand that this is that was a decision point for you all. Some decisions perhaps could be made at this meeting. You know, the board could say, yes, we definitely want to offer this plan. And then when we come back to you in April, we'll have the rates and everything all ready for that plan. That is a theme that we're going to continue through the rest of these presentations that we have for you today, hoping to try to get some decisions made to narrow down your choices coming into the next and hopefully final meeting.
So since this is a decision point, feedback from the board?
And we're talking about the additional plan choice here. Yeah.
Yay, nay? What do you think?
Is there any downside? I mean, I would think that if they think that this would be helpful for their membership, it would be a reasonable thing to do. I don't know what the downside would be to add it.
So the considerations are that if you go back to that prior slide, I think we've got enrollment on there. So there is still relatively low enrollment in Plan 3, which is an HSA style plan, and it's taken several years to get up to that enrollment level. So, I mean, one downside is that is this a plan that not many folks are interested in selecting? It's hard to know at this point. Kaiser has received some feedback from specific entities that they would like a higher deductible plan from Kaiser to offer to their folks that isn't in an HSA style arrangement.
Jeff, this is Susan. And I would say that we tend to always lean toward giving more options to our membership versus less. So I'd be very interested in knowing more about it.
Okay, thank you. Anybody else?
I could say, at least for the membership in my entity, our most popular plan is a plan similar to this, where it's a non-HSA, but it's a higher deductible. So there is an appetite within the Moda group in Southern Oregon anyway for that structure. Although we don't offer Kaiser down here, but that structure is popular.
So is anybody opposed to adding this plan into the mix? Okay, let's move forward with it then. Next decision point on the next page.
Yeah, the next page is it's about the Wellness and Innovation Fund that Kaiser had proposed during the last RFP. So in Kaiser's offer during that time, they put forth $750,000 in dedicated funds to support OEBB's wellness program. And over time, they've proposed the ideas that have centered around three main areas: wellness space mini grants, on-site flu shot clinic support, and the rollout of a resiliency mobile app called Total Brain. And for the most part, these programs have been very popular, especially the wellness-based mini grants, and then to some extent the on-site flu shot clinics. And so the funds that were put forth originally have mostly been used. There is about $100,000 remaining. And so Kaiser has proposed that if OEB would like to continue the wellness-based mini grants and the on-site flu shot clinics when they can be held, that, you know, some additional reserve fund, rate stabilization reserve funds could be used for that purpose. And so they've put forth a couple of options here. Option one would continue those two programs for an additional 3 years and would include 2 rounds of the mini grant cycles. It would require $615,000 in funding. And then option two is basically the same thing, but we would get 3 rounds of the mini grant cycles for the wellness spaces. And that's just under $800,000. So again, at some point, this will be something that the board needs to decide. We can talk when we get to the point, I think, about the rate stabilization reserves, just to review how much is there and whether that seems like a reasonable approach. So I will leave this decision point for when we talk about the rate stabilization reserves. But in general, we're supportive of this because it's been a very well-received program.
So I have a question for Kaiser. These are largely cash transactions. I'm just wondering why the 3rd year would cost less than the first 2 years, unless I'm misunderstanding your program.
Well, I think the additional cost for option 2 is really just the funding of the mini grant cycle. So in each mini grant cycle, and Kaiser may pop in here, that's totally fine. I think there were 40 grants for each cycle. So it's really just funding another 40 wellness spaces.
Yes. Jake, can you hear me?
Yes.
Oh, sorry. Yes. All right. Looks like I'm echoing too. I'll just say you're correct.
And what?
Jenny's comment about the.
So
I'm sorry.
You don't sound echoey to me, Safari. So, but so each mini grant for a wellness space. So again, there were 40 in each cycle in the previous years. So so I don't know if I have those figures at the top of my head. How much funding was in each cycle? I guess we could
think about 175,000-ish.
Yeah,
is what it looks like
for each of the wellness grant promotional programs.
I think, Jeff, where the confusion might be is both options 1 and 2 have 3 years of on-site flu shot clinic support, but option 1 only has 2 of these $175,000 mini grants. Does that help to clear that up?
Okay, yeah, that does. So the proportion of what goes to what. All right.
Exactly. Yep.
Okay, thank you.
Mm-hmm.
Any other questions?
Okay.
Oh, the joys of this. So what's the preference of the board here? Option 1, option 2, I suppose not spending any, but
yeah, we've had, if I remember, Kaiser numbers of the reserve fund went from about 10 million up to about 15 million, and spending 790,000 of the 15 million for something that has been that is positive, has resulted in people feeling better about, addresses the big issues, stress and flu shots, and I think is a winner.
Thank you, Tom. I think I might be tempted to ask, next year, would we have on-site COVID shots?
They did in fact say that if there was a way to support an on-site vaccination for COVID, that they would pursue that with these funds as well.
Good. So Tom's in favor of option 2. Anybody else got a preference?
Bill likes option 2.
That's 2 for 2.
Yeah,
3.
JJ likes option 2.
Bonnie likes
2.
Okay.
I'm fine with either one.
So we have a majority. Anybody opposed to option 2? I'll take the silence as an approval to move forward on option 2.
Okay. So let's talk a little bit about some of the, Moda renewal options. So just as a reminder, where we're starting with on the Moda renewal, the base renewal, before taxes and fees was 4%. Once we factor in the reduction in taxes and fees for this year, the final or the updated renewal is 3.28%. And just as similar to the Kaiser, we are going to get an updated renewal calculation from Moda. However, this position right here is an update from last month. So we've been working with Moda to refine some of the underlying parts and factors in the renewal. So this particular update represents a couple of additional months of claims experience, a reduction in trend that's used to more closely align with what OEB's trend has been, and some adjustments to the downward of the administrative fees. So, the margins being used are similar to the last time. And so this is really just a refinement. So when we get the renewal next month, there will be an update with additional months of claims, but probably not going to be a significant change. Okay. Let's go ahead and move forward and start talking about the changes. Okay, we've got 2 different pages here of changes. The ones we've noted here, all on this page, don't have an impact to the renewal, but are optional. So Moda is proposing them to be included for the final round. Some of these were discussed at CIAO this morning, so many of you may have heard a little bit more details about these, but I'll try to summarize them quickly. So the first one is this steerage or program for MRI and CT scans to encourage members to choose lower cost venues for that imaging. And this is going to be done through the Moda navigators, literally just calling members and saying, there are other options and some of them are less expensive. You might want to consider those. It's a pilot at this. They're going to start as a pilot and then roll it out. So it's going to be voluntary, and so the cost impact is minimal at this point, although it is expected to provide savings over time. The Center of Excellence for Cellular and Gene Therapies. So there are some new gene therapies that are coming out, and this Center of Excellence really just means, again, steering members to use a specialized site of care for those particular therapies. And again, those are emerging and hopefully rare, but so don't have an immediate impact to lowering the renewal, but should over time. The third one on this page is that Moda is going to be using the wellness advisors to help provide ergonomic assessments for entities who are interested in having this service done. So again, a nice added service, but not necessarily a rate impact. And I think I'll just pause there for just a minute to see if there are any questions about those first three. Okay. This fourth one is a proposal to reduce the cost share for generic specialty medications. So right now, specialty medications are all on a co-insurance. However, there are, for brand name specialty medication, there are some programs to help reduce cost sharing for members who have a hardship financially. So there are going to be some new generic specialty medications coming out, and Moda would like to align those with the regular generic copayment, which is $12. At this point, there isn't any impact for that benefit chain, benefit enhancement. On number 5, the kidney disease management program is a program that Moda talked about in quite a bit of detail at CL this morning, but it's really a specialized program to help members with chronic kidney disease to seek, potential dialysis at home, and just to have some additional care management. And Moda is using a vendor for this particular program. So there are some fees involved with it, but there's a return on investment that is guaranteed. And so while there may be savings over time with this program, there's no immediate impact either up or down to the renewal at the time. And the last one is the virtual physical therapy vendor. And again, we discussed this a bit in CL this morning. So the virtual physical therapy vendor, and this is, these vendors have really been emerging recently to sort of help fill a gap. The virtual physical therapy vendors will provide members with digital tools, and in some cases, even a tablet. And in some cases, though, and I think this was the case here too, they'll have, you can attach probes or whatever to different parts of the body that is going through the physical therapy, so that the member can have a physical therapist and a coach who is providing sort of real-time coaching on how to properly do the physical therapy. And the whole goal is to help them improve outcomes, especially for joint issues and that kind of thing, where those procedures end up kind of sometimes evolving into a more significant surgical procedure, like a knee replacement. So this is kind of a way to get ahead of that. So again, this is very similar to the chronic kidney disease in that there are some vendor fees that Moda has for this program, but it is expected to result in savings to at least offset those fees. So there's no immediate impact to the renewal up or down. So I think I'll pause here and see if there are any questions.
My only comment as we look to whether or not CL was in favor of all the ones that you commented on, Jenny, and also Ali, Jeff and I agree that we want to get into some of the greater detail of this, and we'll be looking maybe at the June board meeting to show the entire board the depth of some of these innovative programs.
Good clarification. So, Jeff, I'll defer to you, but it might be a good idea to talk about whether everybody agrees with all of the changes, at least on this page.
Okay. Any questions on this page? Is there anybody opposed to any of these changes? I think we can move forward then.
Okay, good. Okay, Rose, let's head to the next page. So here we have a few other changes, and these we may want to take one by one. And again, the goal would be to say, yes, we'd like to just go ahead and fold this in as part of our final renewal negotiations with Moda when we come back to you next month. Or I'd like some more information about these, and what would that be to help you make a decision about whether to include it in the renewal or not. So the first one is the gender confirming facial surgery. And we talked about this last month, and this has also been reviewed in CIAO. This is a particular procedure to assist members who are going through gender reassignment, either male to female or female to male. And again, CIAO, Tom, you can keep me honest here, but CIAO did commend or agree with the adoption of this benefit change, but it does come at a price tag, so it's 0.2% to the renewal if adopted.
One of the issues is that it's one where we talked about wanting to get KP and Moda in sync. At this point, KP is covering this and Moda is not. I think that was another reason behind it, plus all the recommendations that had, the medical recommendations. And we get this weird situation where we have geographic disparity if something is covered by KP, which represents basically the I-5 corridor and the rest of the state. So if it's not covered by Moda, it means that if you live in the I-5 corridor, you're eligible for a benefit, and if you're outside it, you're not, which is kind of not a particularly comfortable place to be.
Yeah, and this is something that we're also recommending as well, as you can see. Any concerns, or do we want to go ahead and include this?
Well, is anybody opposed to it? Okay, Jenny, keep going.
Okay. The second one is the Moda 360 dental integration. So in this current year, the Moda 360 concierge program was launched, and Moda has talked a bit about some of the early successes of that program. This particular benefit change, or really it's a program change, essentially includes the dental claims into that Moda 360 program. So two things. One is Moda will be adding additional concierge personnel to their team to accommodate the additional questions and outreach that they anticipate from this program. And secondly, there are some data sharing costs associated with getting the claims included into their, their, I guess it's a portal that the concierge navigators use in order to look at all of the claims and encounter information that members have, so that they can help them have the right conversations and give them the right coaching. This is, again, I think Moda talked about that this morning, and
we did.
Yeah,
it was, and CL recommended this one. It recommended number 9 and number 10. So these next 3 are all very small cost implications and made a lot of sense. This is part of that presentation that I talked about, that we would be coming back to the board in June to let the board see at a greater depth.
Good clarification. Okay, so all of these, were recommended by reviewed and recommended by CIO, and we've also kind of looked at them and are recommending them as well. So we'll go ahead and I think look to include all of these in the next round unless I hear anybody who doesn't want that to happen.
This is JJ. I had concerns about number 7, and it's strictly because it's a fairly substantive increase. I do think the argument of conformity across the state is a very strong one. So, I mean, I could recognize that, but I do have the concerns of it. To 0.2 is a pretty large increase.
Okay.
Jenny, do you know of any litigation around the country around gender confirming facial surgery? I know that that's a concern. I heard in Washington there's some litigation around that.
Yeah, that's true. There has been some litigation about against plans for not covering these services. And then I will also say that there's been a lot of legislative requirements that have been put forth in different states to include this coverage, as well as the just the gender reassignment surgery. I can remember maybe 6-7 years ago where coverage of the surgery itself wasn't pretty standard, but again, over time, as people are understanding that this is a needed benefit for many members, then the surgery's been covered, and then now the supplemental services are also kind of go hand in hand really with the surgery.
Would the board like to bring that one line back for the next meeting?
Yes.
Okay, I heard a yes. All in favor of bringing that back for the next meeting, hit the raise your hand button. And Rose can give me a count. Yeah. Okay. I've seen enough in here. So thank you for doing it that way. So no, I appreciate it. People want a chance to think about things a little bit more. So my next question is on, so then 8 through 12, does anybody have an objection for moving those forward? Okay.
Did we have a discussion on 11 and 12 before or not? Not that I'm necessarily opposed to them. I just can't remember.
Thank you, Robert. These are federal mandates, really.
I don't think they're mandates. I think they're just maximums. So it's whether we want to conform to the maximum or not.
Yeah.
It wouldn't make any sense to offer an HSA plan that doesn't conform.
Well, you're legally allowed to be less. You're just not legally allowed to be more.
Yeah. Yeah. So for a little bit of context, number 11, which is the maximum cost share, and I did put together 3 or 4 slides in here just to explain this if you'd like to go into a bit more detail. But the maximum cost share, as was pointed out, is something that is included in the Moda plans 1 through 5 and is has traditionally been on the Moda plans been indexed up every year to align with what the federal maximums are. So the federal government is the one that sort of sets the maximum amounts of cost sharing for medical and pharmacy costs for all plans. And so again, plans 1 through 5, that's traditionally been done. And if you do that again this year, which is what we would recommend, then it would provide a 0.03% reduction to the renewal. So the one that is not, that hasn't been done every year is the out-of-pocket maximums on plans 6 and 7, and those are the HSA style plans. So the IRS sets a slightly different maximum out-of-pocket limit for those plans. And I think the Moda plans have sort of evolved through various iterations, or when they've been newly introduced or when they've gone through a change, there have been some changes to the maximum out-of-pocket. But I don't know that we necessarily have a precedence for increasing the out-of-pocket maximums automatically every year on those plans. However, if you're increasing the max cost shares on 1 through 5, it makes some sense to also do it on plans 6 and 7 to just ensure that you have the right amount of space between the plans and that the value of the plans are change consistently over time with each other.
Okay, relativity.
Yes.
One thing I think we should consider is we did an assessment, I think it was a couple meetings ago, looking at Moda's value of our plan structure versus national averages, and our maximum costs, max out of pocket, max cost share, were quite a bit higher than what you see typically public sector insurances. And part of that is we have elected to just do whatever the federal maximum is, and a number of agencies across the country have chosen not to do that. So I would be in favor of not adopting these two, because I think that it just passes that cost to the employees.
Would you be in favor of including 11 and 12 in further discussion next month?
Yeah.
And we approve all the others?
Yes.
So 7, 11, and 12 will carry forward in discussion, and the balance will be assumed to be adopted. Is that agreeable to everybody? Any opposed? Robert? Oh.
No, sorry, that was a mistake.
Okay, so we're not rejecting 7, 11, or 12. We are just going to include those in next month's update for discussion. Is that good?
Sounds good.
Okay, so the next few slides really are just backup for those last two items. Went into a lot more description about things like federal cost sharing limit. I can review those with you if you like at this point, or if you'd like me to hold that for next meeting, I can do that as well.
Does anybody want to have some preliminary discussion today? Robert?
Well, I think if we're going to consider it for next time, it'd be good to have some exposure to it now so I can ponder.
Okay, let's do that.
Okay, so the purpose of these couple of slides here is to really provide some education on what is a maximum cost share and how do they, there's 3 or so different ones out there, and how are they the same or different. So as we discussed before, the federal government sets some cost sharing limits on medical plans. Now, the Health and Human Services Department has determined sort of what they think the maximum amount of medical and pharmacy costs a member should pay in a given calendar year. And those apply to any plan, and it's part of the Affordable Care Act. So those are noted here in the top row, max annual cost sharing limit. So the Health and Human Services said, an individual shouldn't have to pay more than $8,550, and a family altogether shouldn't have to pay more than $17,100. Now, just to be confusing, I don't know, but the IRS is responsible for determining the out-of-pocket maximum for HSA plans. So that's plan 6 and 7, and for Kaiser plan 3. So they've determined that the most a member should have to pay for medical and pharmacy costs for an individual is $7,000. And then a family, the most they should have to pay is $14,000. So this is not something specific to OEB. All plan sponsors have to think about both of these cost sharing limits when they're determining what plan to come together. So that's just your background about who sets them and how they're not similar. So if we go to the next slide, I think this is the Moda. I have to remember what, I think these are the Moda plans. Yeah, so these are the Moda plans 1 through 5. So Moda, and you know, the way medical plans work with a lot of carriers is Moda sets a specific medical maximum out of pocket. And so you can kind of see there on that row that says medical max out of pocket. So for instance, Plan 1 has a medical maximum out of pocket of $2,850. And what that means is once a member has spent more than, has spent $2,850 on medical expenses, so pharmacy's not included, then everything else is covered at 100%. However, to comply with those federal requirements, there is embedded within the Moda plans this max cost share. And it, again, lines up with what the federal government determines is the maximum amount. And that is where medical and pharmacy comes together. And some other things that apply to that would be co-payments for the additional cost tier that a person pays, stuff like that. So that's the difference between the medical maximum out of pocket and the max cost share. And again, this currently is $7,900 and just has indexed up every year on OEB plans. So we're not talking about changing the medical maximum out of pocket. We're only talking about changing that max cost share for these plans. And then, so Rose, if we go to the next slide. So the next slide, this is plans 6 and 7. So these are the high deductible health plans. So plans 6 and 7 do not have a separate max cost share because the way plans 6 and 7 work is that all medical and pharmacy costs accrue to just the one out-of-pocket max. So in this case, currently it's $6,400 for Plan 6 and $6,500 for Plan 7. And so again, if you adopt the plan change that's being proposed, those would index up to $7,000 for a single and $14,000 for a family. Some of the reason to do it would be to just ensure that there's a meaningful difference between the plan 6 and 7 and plan 5, which is right below it. So that's really kind of the background. You can see I've listed here the number of folks who have met this maximum out of pocket. There's still some members who have met the max out of pocket, but it's a relatively low percentage. Okay. Any questions?
Unfortunately, we need to pick it up a bit.
I think we're just almost done. Go ahead, Rose, to move to the next slide. Okay, so we'll come back with kind of revised options here at the next meeting, but so I think we'll just do that at the next meeting. We can go ahead and skip this page. Okay, the rate stabilization reserve accounts. This is just a quick accounting of where OEB is with the different rate stabilization reserves. So the projected balance as of September 30th for Moda is 26.2 million. And for Kaiser, it's 15.4, as was mentioned a little bit earlier. At this point, we're not recommending any use of the rate stabilization reserve funds except for the Kaiser wellness space grants and flu shot clinics. Any questions about that?
So we'll have further discussion on this at the next meeting as to whether or not we want to use any of it and what would be an appropriate amount.
And I think I've got a slide in here about what's coming up next, but we can probably save that for the afternoon.
Okay. Good, thank you, Jenny.
Welcome.
So next we have a presentation from Dr. Barrichello. discussing why we're entertaining an additional EPO dental plan option.
Perfect. Thank you. Good afternoon, everybody, and thank you for allowing me time on the agenda to introduce a new EPO plan for your consideration for the 21-22 renewal. Rose, go ahead and go to the next slide. So let me start with an overview of what our EPO or exclusive provider organization plan is. We currently offer one EPO plan for OEB, and it was first implemented in 2017. It's a high value plan, meaning members get richer benefits at a lower premium point, but there are no out of network benefits. So members must see one of our PPO providers in this plan. PPO providers are contracted at lower rates, which means a member's annual max will cover more services. Our PPO network is a narrow network. Providers agree to the lower reimbursement due to the steerage of patients to a lower cost provider. As is the case with our Premier plans, PPO providers cannot balance bill the member. So this arrangement results in true cost savings for the plan and for the member. And although it's a narrow network, it is comprised of over 2,700 access points with over 1,300 unique providers across Oregon. Go ahead and go to the next slide. So due to the narrow network, it's very important that members have clear communication about how the EPO is structured and inform them about the out-of-network limitations to guide them in their plan choice. And our team has been really diligent from the very beginning in ensuring members and entities clearly understand the plan. So detailed information has been included in all of our presentations to the insurance committees and at open enrollment meetings. We followed up with letters to entities and letters to subscribers to further ensure that members are making informed decisions. Go ahead and go to the next slide. So this is a snapshot of how the current EPO plan has performed as it relates to interest and engagement by members. So you can see from the time it was introduced in 2017, the number of entities that have decided to offer the EPO option has grown. And then broken out below is enrollment over time. So you see the member count and then the percent of our own Delta Dental enrollment that makes up. So we saw good growth through 2019, and I might rely on Erica to help me describe why the proportion went down in 2020. I believe that the overall enrollment went down, which sort of skewed the numbers a little bit.
Yeah, correct. There was a decrease in overall enrollment for the most recent plan year.
Thank you. Okay, go ahead and go to the next slide. So I'm going to get you guys caught right back up on your timing. So our proposal for the 21-22 plan year is outlined here. The two key differentiators are that the new plan, or this new option, greatly increases the maximum and includes the incentive structure. So preventive care would remain at 100% to ensure that no barriers are to seeking preventive care, and that and then the basic and major levels increase over time as long as the member is seen for a preventive visit, which this is generally consistent with our other incentive plans. And then there's an appendix at the end of the slide deck in your packets if you want to see how this proposal stacks up against the rest of our Delta offerings. But essentially, it would sit in the very middle in terms of a premium price point, and it would have the highest benefit maximum. And that concludes my overview of our proposal, but I'm happy to take questions. Or actually, I should say, Erica and I would be happy to take questions.
There you go. So how have retail dental prices gone up in, say, the last 10 years? And how does that compare to dental plan maximums in general over the last 10 years?
Well, I can take that question a couple different ways. So we obviously within our own Delta system and contracts with dentists, we manage the fee increases every year very, very tightly. But I think your question maybe is more at like market rate, dentist market rate.
Yes.
So yeah, dentist market rates have increased, and I would say, you know, in particular the last year with COVID, their dental offices are experiencing higher overhead costs from a number of different fronts, but largely driven from new infection control protocols and new standards that they have to implement. So that is, you know, that is something that we're really mindful of. As it relates to the maximums, no, I mean, we haven't seen maximums significantly increase, but I would also point to in years past, and as we've done our annual cost and utilization, there is we pull out the statistic for the number or percentage of members that are actually reaching their maximums, and we haven't seen that dramatically change year over year. And I would probably need to, I can't speak to the details on that. I'm speaking from memory. So I would need to go back and have our team run the numbers to be able to put that in front of you. But I believe in general, with our entire book of business, the number or percentage of members that reach the maximum is generally around 4 to 5%.
Okay. Tom.
My question, I don't understand what you mean by incentive. So I understand, so basic restorative at 90%, I get that, and major at 80% with the current one. I don't understand what incentive means there.
Sure. So and Erica, I'm going to probably ask you to help me out on this one to make sure I'm using all the right words. But so for other of our premier plans, members for each, they enter the benefit year at like year 0 or year 1, I guess, with say restorative being 70%. But if they get during that first year, if they have a preventive visit, then the following year that restorative share.
I remember
it
now. I get it. I remember it now. Yeah. So they build up coverage as or percentage of coverage as they've come in for preventive visits on the proper scale. Got it.
Yes.
Yeah.
Exactly.
Yeah.
And as we've talked about, Tom, in CL meetings in the past year or so, and I know that looking at preventive utilization by members has been really important to OEB, and our incentive plans perform extraordinarily well, and we recognize that the our EPO option was I guess lagging just a little bit behind that, and so this offering would sort of helps build in that structure to help drive that preventive utilization.
Sounds great. Thank you.
So this would put this concept on par with Plan 1, roughly.
It from a maximum standpoint, it actually would exceed Plan 1. And Rose, if you want to go to the appendix, I think it's 2 slides down. We can maybe look at that. We don't want to rely on my memory. There we go. So that's where you can see the plan stack up. So you can see that our proposal at $2,300 is $100 more than the maximum on Plan 1, and it's $43 less than Plan 1. $23, sorry. Don't rely on me for math either.
Okay. Any discussion on whether we should pursue that option? Yay or nay?
Sounds good.
There's one.
Agreed. Sounds good.
Yeah, it's fine with me.
Okay.
Yeah, I'm fine with that.
Anybody opposed? Okay, we'll carry that forward. Thank you. That brings us up to our break at 2:40, where we'll be back together in 11 minutes.
Are you still here?
Okay, let's reconvene. I think we're back to our consultants for part 2.
I'm here. Yes, we're part 2. Do we have most everybody back, do you think?
Yep, should be.
So we're going to continue the renewal discussion by talking about the update to the dental renewals, the vision, and then we've got the EAP and COBRA renewals to talk about today. Go ahead and go to the next slide. Thanks, Rose. So again, the purpose of today's meeting is to review some of the benefit changes that are being proposed and to move them forward into final approval or move them into consideration for the next meeting. Okay, let's go ahead and go forward. So this is our just high-level summary of the dental and vision. Oops. Yeah, there we go. High-level summary of the dental vision renewals that we just talked about a little while ago. So Kaiser and Willamette Dental, their base renewal, including changes to taxes and fees, is at 0. So, you know, if we renew as is, members are really going to see no change to their rates on those 2 plans. The Delta Dental plan has been updated, and we'll talk about that, but it's at 0.59% increase. And then you can see that there are some benefit changes that we're going to talk about today that are benefit enhancements to promote preventive care. And if those are adopted, it would increase the renewals by an additional 2 to 3%. So we'll talk more about those. The vision renewals, there's only an update to the Moda renewal. So Kaiser at this point is at a minus 0.59%. Moda is at 1/3%. And VSP is at minus 12%. And nobody proposed any plan design changes to the vision. So at this point, the board could essentially consider and approve the vision renewals if you so choose today. For the EAP, we'll talk a bit about the EAP, but the bottom line to the renewal is that Reliant is not proposing any change to the fees for an additional 3 years, but there are some enhancements to be considered. And Benefit Help Solutions, which is the COBRA administrator, is proposing a very slight increase to their administration fees. Okay, we can go ahead and go to the next slide. So dental renewals, really the only update to the base dental renewals is on Delta Dental of Oregon. So they've reduced their preliminary renewal proposal down to the 0.59%. And really a lot of that had to do with the additional claims experience and removal of dental margin. And again, all of these are inclusive of the change in taxes and fees. So let's move to the next slide. We can start talking about some of the plan design changes. Really, this is a summary of what Dr. Barrichello was just talking about. Moda technically presented 3 possible options for a new EPO plan design, and they're labeled here A, B, or C, but it sounds like Moda is recommending of the 3 that the plan C would be the one to be added if the board, and it sounds like the board is interested in moving forward with a new EPO plan design. Okay. Any questions? Okay. So on the next slide, a couple of slides, we're going to talk about preventive care. So just as a background, the reason we're talking about an enhancement to preventive care is that when CIAO took a look at dental utilization within OEB, a couple of things were highlighted and have been a theme over the last several years. So there's pretty high use of preventive dental care under the Delta Dental plans. So they're at 72%, but the Kaiser and Moda, or sorry, the Kaiser and Willamette Dental plans we're seeing lower use of preventive care under those 2 plans, and that has been a theme for several years. So Kaiser's at 44% of dental members have had one or more cleanings, and 48% of Willamette Dental Group members have had one or more cleanings. And so Dr. Siltabo asked the group, all of the dental carriers, to get together and sort of brainstorm ideas for improving or increasing the amount of preventive care, or ways to encourage preventive care, especially among the Kaiser and Willamette Dental Group plans. And so just as background, you know, some of the ideas that were discussed and have been done is that Kaiser and Willamette Dental have done some additional outreach targeted to members who have not been in to have a cleaning in some time. And then we also did a spotlight in OEB's wellness website in February on the importance of annual dental visits. So that's, you know, it's all great news, and it may take some time for those actions for us to see the results of those actions, especially since, you know, COVID does put a little bit of a, I don't know, a wrench into some things. Now, we've seen that for the most part, dental care is back to normal, but I think that's for folks who had already been comfortable coming in for preventive care. So those are all great efforts, but we also said, why don't we take a look at if there's anything we can do from a benefit design to remove any barriers that people might have to coming in for their annual preventive dental care. So on the next slide, we'll talk a little bit about a couple of the options that we asked the carriers to propose on. The first one had to do with just reducing the copayment for preventive visits. So Kaiser, we'll just kind of looking at this table. So Kaiser has told us that they are able to identify preventive visits versus all other visits. And so if the board wanted to reduce the copayment for Kaiser on preventive visits from $20 down to $0, you know, they can do that, but it would be an impact to the renewal of 2.14%. On Willamette Dental Group is not specifically able to identify preventive visits versus all other office visits when it comes to copayment collection. So what they're able to do administratively is, well, if you wanted to just reduce the copayment from $20, what it is currently, down to $10, and that would apply to all dental office visits. That would be a nice benefit enhancement, but it would increase rates by 2.75%. What Willamette Dental did come back and say is, and Tiffany, I think, presented that this morning at CIAO, I think it was this morning, that they could sort of manually just waive any initial copayment for any OEB member who has never had a dental visit but decides to come in. And obviously there would need to be some additional communication to encourage that benefit from happening. And they're willing to go ahead and do that at no impact to rates. And then Delta Dental, although there is already very good use of preventive dental services under those plans, Moda or Delta Dental has been promoting a benefit that they call Preventive First for a couple of years now to the OEB group. And this is a benefit that they have in place with many of their commercial clients as well. And how it works is that members who have preventive dental services, those services would not apply to the annual benefit max. So while it's not necessarily an encouragement for preventive care, it just sort of helps stretch out the members' dental benefits for when they have, you know, more significant dental costs. And you know, doing that is a benefit enhancement, and it would be an additional 3.13%. Wouldn't necessarily be applied exactly equally, but among the dental plans, but there would be a varying effect depending on the value of it. I think it's important to note that most of a number of the Delta dental plans already covered the preventive services at 100%. And even on the incentive plans, there are a number of members who have already reached that 100% level and are getting their preventive care covered in full. So those are our options. We've gone ahead and just recommended the reduced copayment on the Kaiser plan, and Willamette Dental's offer to waive the copayment for anyone who has never had a visit. But certainly open for discussion. Any questions about these options?
So if you're, oh, I got an echo. Now it's my turn with the echo. So the decisions we make today shorten the meeting next time and allow us more time to discuss those points. Of this list, what preferences do you as board members have?
Jeff, this is Sue. I guess I just want to make sure I'm clear. Do we believe that it's the copay that's holding people back?
I have the same concern.
I mean,
So we should hear from the people proposing them.
Yeah.
Sapari, are you there? Starting with number 1.
I am. Can you hear me?
Yes.
And you're not hearing an echo?
No.
Okay, thank you. When we looked at our book of business, it appears that as the copay decreases, utilization increases.
For prevention?
Yes.
Okay, great. Then it's thumbs up.
Well, what do we have on the Moda plans or the ODS plans?
Yeah.
Delta Dental.
So yeah, Delta Dental. So the incentive plans all start at 70%, and then you can earn your way up to 100%.
No, on the preventive, Jenny. I'm sorry, I didn't answer the question right.
Yeah, I think that is the way it works on the preventive as well. And that's the way it is on plans. I think I've got a slide here. If we go back a slide, Rose. Okay, slide 7. Yeah, so here are the Delta dental plans.
So it's 100% on 6 and 7.
Mm-hmm.
Mm-hmm.
For preventive and diagnostic. Okay. Sue, that doesn't answer your question directly. It does address consistency.
Yes, thank you.
Yeah, it's, do you want to have a better benefit but a higher premium, or do you want to keep the lower premium and the benefit the way it is? And there are valid reasons for both, honestly.
Yeah. So we have a really good renewal going at this point. We've had a couple of additional plan options that don't cost us anymore. Do we want to raise the cost on any of the existing plans? Would be a question. Do not infer an answer to that. So what do you think?
Well, my first thought, Jeff, is that I want to encourage our members to get preventative care.
Okay. All right.
And if, certainly if a $20 copay is holding them back, that gives me pause relative to, raising deductibles in any way, shape, or form if we can help it.
Anybody else?
If Susan Miller's still on, I'd like to know how she thinks that impacts her members.
Yeah, I am still on. I'm not really sure, actually, Robert. I mean, I would say I would pretty much echo what Susan Ricky Smith said. We want to promote preventative care, and you know, if raising deductibles is going to prevent that, then we wouldn't want to go that route.
Sapari, can I ask you two more questions? Do you predominantly offer plans without a preventive copayment at Kaiser?
It's a mix, Jeff. I'd have to pull the data on that.
Okay, and then the second part to that would be those plans that have the preventive copay waiver, do they have different renewal? And is there a difference in the renewal actions?
For this time period?
I mean, no, do they generally go up at the same rate as the rest of the plans?
Oh, sorry, that's another question I would have to look into. Don't want to give you the wrong answer.
Then I have another question for Sapari too. The increase of use if there's no payment. Is that, you know, the book of business? Are we talking about that it would definitely that idea would transfer over to OEB subscribers and beneficiaries too?
Yes, great question, Robert. It is our book of business commercial.
The reason I ask, I'm not sure if the barrier is the same for the people on OEB as it is for the whole book of business. I just don't know.
Sure.
Sounds like we need time to get some more information on this one.
Well, this is Bill. Can I also chime in that, you know, I kind of scratch my head with Robert as well, but I'm wondering why we can't put some incentive in to push members towards connecting their dental and medical through Moda 360 and Kaiser to get the additional benefits of what was discussed about how periodontal disease affects systemic overall health care, you know, and we want to bring those two pieces together and make some incentive to make that happen for a larger cost savings.
Interesting question.
Yeah. Rose, can you take us back to the current page, please?
Slide 9.
I think so.
Jeff, this is Tom.
Yeah.
I think that the issue that Bill raised is one that we need to have further conversations about, probably at CIAO, where we look at where we start talking about that type of medical dental integration, because the issue is, you know, there's people who have Kaiser Dental but don't have Kaiser Medical. There's people who have Kaiser Medical who have Willamette Dental or have Delta Dental, and the question is there data, is there evidence that suggests having those actually in one system makes sense that would result in better outcomes? So that's one that we need to think about.
An additional comment from Bill is, for me, that it also triggers the automatic reminders that Moda 360 has, as well as giving the member information about that connection to overall health and periodontal disease, and why preventative is a bigger picture, not just saving $15.
Yeah. And I think the same thing could be probably said for KP's people in that system. So I think we have to explore that question to a greater degree.
That's all I had. Thanks.
Sapari, is it Troy that's on the dental side?
Nick.
Okay. Perhaps he could join us at the next meeting. And It seems to me that this is a step towards that direction that you're talking about, Bill. It's just not the complete answer.
I agree with Robert that it's a little more incentive than just taking a couple, $20 off your annual preventative cost.
Okay. So we'll continue that to the next meeting. Line item 2, yay, nay, do we go along with our consultants?
Lowering the copay for everything doesn't get at what we were hoping for. We were hoping for some impact on the on prevention, and I think that what they've done in number 3 is I would be very interested in seeing how that impacts things as compared to just in general lowering copays for everything.
Yeah,
I agree.
So any other comments? So are we then in agreement that we will not adopt number 2?
Do you want us to raise hands?
That is my position, yes.
Anybody who would like to discuss that further, give me a hand sign. I need a little musical thing like a game show. Yeah, okay, nobody says. So that one, we follow the consultant's recommendation and decline on that. Number 3, yay or nay?
Yay.
Yay.
2,
Yay.
3,
Yay.
4,
Yep.
5,
Yay.
6. Okay, that one passes. Number 4.
It doesn't address it doesn't address prevention services. It only changes the what the annual maximum benefit is, which is something that you can. I don't think it. If our goal is to improve prevention, this doesn't, I think, do anything.
Agree with Tom.
Yeah, me too.
3,
Agree.
4,
Agree.
5,
Agree.
6. That's a majority. Okay, so we are going to accept Willamette Dental Group's offer on initial co-payment waiving, and we are going to carry forward to the next meeting Kaiser's reduced copay for preventive. Next page.
Okay, good. We'll have to look into ways to do polls. I think their teams does have a way to do a poll, but I don't know how to do it. Okay, vision renewals. So these, the only update here is that the Moda renewal is slightly refined. And so, at the end of the day, we're at a slight decrease for Kaiser Vision. We're at a very slight increase for the Moda Vision, and we're at a pretty good decrease for VSP's 2 vision plans. And Moda's updated renewal is really just refinement of trend and the updated claims experience. At this point, we're not expecting an update on the vision renewal, and there aren't any proposed changes to the vision plans. So the board can, we recommend adopting and accepting the renewals as proposed. So this is a time for you to decide to do that or ask any other questions.
Questions? All in favor of adopting that as final, raise your hand.
Aye.
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 Opposed? Okay, Jenny, you can just include it as a line item next month for the total.
Okay.
Thank you.
Sure. Okay, let's talk a little bit about EAP. Go ahead and go to the next slide, Rose. So quick just reminder for those who may not be familiar with an EAP. EAP stands for an Employee Assistance Program. Many employers do offer a program like this to their employees. What an EAP is it's a service to help employees kind of cope with day-to-day stresses by making available some visits to a therapist to address what what those stressors are. And they may be work related, they might be relationship related, children raising related, those kinds of things. So an EAP, if an entity elects to offer an EAP, it's offered to all employees and their family members, even those who are not enrolled on a medical plan. So it's not really related to who's on the medical plan or not, or who's waived. It's offered to everybody. And the visits to a therapist are at no cost to the member. So it's usually a really nice enhanced benefit to help their employees. Additional services that are offered by an EAP would be providing personnel therapists to go on site at an entity to help with trainings on specialty topics like resiliency or social injustice has been a recent topic. Another item is, I don't know if there's a little bit of background noise for me, so I'll just plow through though. Another really important service that an EAP provides is critical incident stress debrief. And so that happens when, if an employee passes away or a student or there's a shooting on campus, so some really severe situations, then the EAP can send out several different therapists to sort of be on site and help the employees cope with what's going on and talk with someone to get help. And they can also provide managers and supervisors with assistance to help on job performance issues. And finally, kind of a lesser used service, but very important, is they can offer employees help in finding a caregiver for their children or if they're taking care of an adult family member. So that's a background about what an EAP is. Let's go ahead and go to the next slide. I did include, just for background, a couple of survey slides on some surveys we've done, because EAP and mental health has been a real big focus for employers during this pandemic. So we've asked in this recent survey that we did late last fall, a lot of questions about how they're handling the pandemic. And one of the questions we asked is, what's your organization, to what extent are you facing workforce challenges, and what are the things that are you're worried about? So rising stress and burnout is number one. Higher mental health claims, number two, which we did see in OEB data this morning in CIAO, and some lack of social connections is the third item here. And these are all three areas that an EAP is perfectly aligned to help address as a first line of defense. Obviously, if someone has some really significant mental health issues, then they move on to the medical benefit. But what we've been seeing, I'll just say in general, among employer plans, is that even though the EAP is excellent, is an excellent resource for these types of issues, there's been a decline in utilization overall among a lot of employers. And there's been a corresponding increase in the medical use of behavioral health. And, there's a couple of reasons for that. Maybe some of it is folks just sometimes don't remember about the EAP and don't use it. And their first thought is to go directly to their medical provider. A second reason is that this isn't just for EAP providers, but it's for mental health providers in general. It's sometimes challenging to find a provider that you feel comfortable seeing and be able to get into that person within a reasonable amount of time. A lot of times you call the EAP, they'll say, let me give you the names of 5 or 6 providers, and then the member or the family member has to start calling to see when they can get in. And it's just, it's a fair amount of work to just get in for that initial visit. So for all of those reasons, we're seeing some decrease in utilization, even though these 3 items are top on employers' list. So on the next slide, on the next slide, we talked about, we asked employers, okay, so if, stress and behavioral health is one of your big demands, what's driving that? What are the big stressors? So here we've asked in the public sector and education, very similar to some other employers, caregiving demands, kind of number 1, social connections, and then worry about COVID. Those are all things that are, I'm assuming many of you are hearing this from your members or stakeholders as well, that these are big concerns. And again, these are all things, maybe not the COVID piece, but the caregiving, the social connections are certainly things that an EAP can help provide some resources and advice on. Okay, so those are our background slides. And now we'll talk a little bit about the actual renewal from Reliant Behavioral Health. If you go to the next slide. Okay, so OEB provides 3 different options for EAP to entities, and the entity can decide what model fits best for their population. And it's also a voluntary program, so not all entities need to offer an EAP, but many of them do, as you'll see there. So there are either 3, 5, or 6 visit models, and what that means is either 3 visits to a therapist, 5, or 6. Traditionally, these have all been face-to-face visits, so someone calls, again, makes an appointment and goes to see the therapist in his or her office. But just like everything else, a lot of digital or virtual options have been made available, and RBH has also been making virtual visits available to members as well. So what you can see on this slide is the different charges for the different models. 80 cents per employee per month for the 3 visit model and so forth. So again, Reliant is not proposing any changes to their current fees, and these are the 80 cents, the $1, and the $1.16 are all within the competitive range. Any questions on this? Okay.
Jenny, you had said that utilization had dropped. How much has it dropped this last year?
Yeah, let's
I
go
guess
and
that's
look at
the next slide. Because
slide.
my question is, it's great to see it not increase, but if utilization, fell off the cliff, we should be seeing something less.
Yeah, so utilization has been decreasing over the last 3 years. So in 2017, it was at 19%, and now we're down to 11%. I will say that those numbers are much higher than what we typically see. Sadly, EAP utilization averages hover around 7%. So they're still above average, but it's been declining. We did talk with RBH about this, and so they've got some thoughts about how to improve. I think it's the visibility, because it's a really great service. I think what happens is folks just don't remember to call.
Yeah. When I looked at this and thought about it, I was to see a decreasing utilization of significant amount, and the idea of cost staying the same doesn't make sense. Now, this year, I understand it really falling off the cliff because of the place, schools closing and going virtual. So I understand that also, but I was surprised that there was not an acknowledgement of that significant. I mean, if we saw a 40% decrease in medical utilization, we wouldn't be expecting a 0 change in rates.
Yeah. Well, a couple things. So OEB has had RBH in place for think it's like 8 or 9 years. And there hasn't ever been a change to the cost structure since that time. So they haven't ever had an increase. And then I guess the other way to say this is, this is the per employee per month fee. So even if utilization increased significantly, OEB, the entities are still going to have the same cost. Yeah. I will say, just sort of at a higher level, what we're talking about with a majority of our clients, especially the really large multi-state clients, is that this issue of the EAP being helpful but not fully addressing employees' issue has been a topic that we've been talking about quite a bit this year. And there are a number of newer specialty vendors that have come out and are really making a mark on this industry. And so those are vendors like Spring and Lyra, and to some extent vendors like Maru that Moda has put into place, where they really do, number one, they have a unique provider network. So it's not the same providers that are offered, it's usually different providers that they either employ or that are specific to that vendor. And then there's, their claim to fame, if you will, is that they have some really robust digital tools to help folks understand what's going on and let me hook you up with a provider within a day. So that's, removing the time period does increase utilization, but the downstream effect is that it helps the employee get over their situation better. And there's been a number of studies that have shown that it actually reduces mental health utilization and pharmacy use. So certainly something to consider exploring a little bit deeper. And that's one of the recommendations, even though we're recommending going ahead and renewing the EAP at this point, we do think that it would be helpful for OEB to consider at least what's being offered out in the market.
Got it.
So I think on the next, yes, there's another question.
Yeah, I have a question as it relates to law enforcement. I know we've used EAP when law enforcement has had interactions with critical incidents, either car crashes or shootings. Officers that are involved in a shooting have like a 50% attrition rate within 5 years. If you're involved in a shooting, you're probably not going to be a cop within 5 years. And EAP is very helpful in dealing with the post-traumatic stress associated with having to take a life. However, we've had limited results in having a quick turnaround. And so I was curious if you've talked about some specialty vendors, if any of these folks have had specific experience with critical incidents in law enforcement.
I would have to get back to you on that one.
All right.
But happy to do that. Okay, so let's go ahead and I think on the next page, there's just.
Excuse me, I was on mute.
Oh, go ahead.
I would propose that you go back to them and say, not a 3-year renewal, but a 1 year at a reduced rate. The second part of that is, yes, they've offered to think of ways to increase participation, but I'm not sure we need to pay for that. So I think 1 year and we evaluate. And
I agree.
Maybe we take you up on looking at contemporary vendors.
Yeah.
But in the next month, ask them to come back with a 1 year adjustment.
I would just tell you, Jeff, from my perspective, regardless of usage, the fact that we had it was a major deal in our community. The fact that our staff knew it was available to them. So I wouldn't underestimate the importance of that.
Okay.
I don't think we're
appreciate that.
talking. I don't think we're
we're
talking about
talking
eliminating
about doing
it.
away with it. I just
Yeah.
think we're talking about value.
Yeah. Understood. Okay, so this is,
I see nods.
Okay.
So anyway, I'm just going to stop for a second. I'm kind of uncomfortable with how we vote or how this goes. It's trying to do it verbally is frustrating. Roll call is burdensome. How are you folks comfortable in voting on things? Brief discussion.
If we were in the meeting, we would hold a motion, and then we would say yay or nay. I think that that's continued to be an appropriate response, or you can even do the hand raise. That was, I think, an easy way to show if the answer is yay, raise your hand. That also works pretty effectively.
I would agree with JJ.
Same, I agree with JJ. Raising the hand that's something you can count quickly. People can do it quickly.
And Rose, are you able to capture those votes?
Yes. Are you asking me if I can show them?
No, just can you
No.
record the number?
Yeah.
Because I just see it go by real fast on my screen.
Yeah.
Jeff,
Okay,
Jeff, it shows up when you have the participant feature open on the side. So you can see actually the names and the people with our hands up.
Mm-hmm.
Okay, let's give this a shot. So all in favor of asking RBH to come back with a 1-year renewal at a reduced rate, vote yes. Okay, I think I've got everybody on this first page here. And it looks like we have 7 votes in favor of that. Okay, take it down. And anybody opposed, vote. Okay. We asked for the 1 year.
Okay.
Thank you, everybody. I appreciate that.
That's helpful. Yeah, real quick, I do want to just mention on slide 19, if you go to that, Rose, we're keeping you on your toes today. So we will go back and talk with RBH about the 1-year proposal, but if you go to slide 19. There we go. They did propose a couple of additional enhancements, and these are enhancements that an entity could select to offer on top of either the 3, 5, or 6 visit models. The first one is digital behavioral health coaching. So again, this is, I think, similar to the Maru offering that Moda has. Again, it's just under the medical plan. This would be for EAP, and that's 50 cents PEPM, again, an optional buy-up. And then the extended version of that would be, instead of just 4 weeks of coaching unlimited, and that would be at $1.50 PEPM. And then the second buy-up option is this Caregiver Plus. So Caregiver Plus, Reliant Behavioral Health will actually provide resources, people resources to help employees and their family members just to do certain tasks. So some of it might be transportation to healthcare appointments for, maybe an older parent, errand assistance, yard work, getting to medical appointments, food, grocery delivery, those kinds of things. So it's for those employers that have put it into place, it has been very popular. And so for that reason, they've got kind of a stepped approach to the pricing. So the pricing is, and again, this would be an optional buy-up for an entity, so 67 cents PEPM. But if there was more than 5% of the population using it, then the pricing would go up 34 cents for each additional 1%. So,
does each entity have the option whether to offer this or not?
yes.
Okay. Questions?
Well, I have more of a comment. You know, if utilization of EAP is low because of what, a lack of exposure or you know, a lack of people remembering or whatever that is, then then that same problem is going to happen with these 4 options, won't it? I would rather see an improvement on utilization before we add other pieces, but I'm open to doing it.
Yeah, it doesn't hurt to have these as options that entities could choose to add. I'm not sure the first 2, the behavioral health coaching, both our medical plans offer it. So I don't think that they would get much interest in that. The Caregiver Plus is kind of an interesting concept. And yet, again, an entity that's struggling financially, I mean, and all of our public entities are struggling with costs. I can't imagine them doing it and offering something new, but it doesn't hurt to offer it, the Caregiver Plus, or and for that matter, the digital behavioral health coaching, because it's something that they can choose to take or leave it.
So the question is, if we're offering yet another plan here, are we taking away from the integrated plans of which we're trying to get interaction between?
Yeah, I think you're right. Particularly the digital behavioral coaching things.
Yeah,
that's where we're looking at our health plans to offer that.
Is there a motion?
I think we should hold off until next week because we're going to look at the cost structure, or next month, because we're going to look at the potential cost structure change next month.
This is Susan, I second that.
Okay, hit the hands. All in favor? Six. Okay, thank you. Passes. The motion passes. Okay, I think is that it, Jenny?
One more.
Okay, we have Jeremy Vandehay in the wings, so I just.
Well, yeah, we can certainly wait on the COBRA until next month if you like.
Ollie, do we have Jeremy ready?
Yep, Jeremy's all teed up.
Okay, thank you, Jenny.
You're welcome.
Jeremy, welcome.
Thanks, it's great to be here.
His introduction's on our agenda, I believe.
Jeff, did you want to tee this up or you want me just to dive in?
I'll tee it up. So the initiative for the collaborative partnership on value-based payment, we've had the principles presented to us in a prior meeting, and there was a request for the board chairs to sign a document approving this collaborative. And Robert and I reviewed that, and we're only comfortable signing it on a as ratified by the board basis. So we gave the encouragement to keep going, but the final is per vote today. You want to add to that, Jeremy?
Yeah, thanks, Jeff. Just a bit of background here. I think you guys probably talked about this before, and for folks who don't know me, I'm the director of the Health Policy Analytics Division within OHA, which has a number of things under it, including PEB and OEB teams. I think folks know, but just a reminder that this work is sort of a spin out of a larger body of work over the last couple of years to really get our arms around statewide healthcare costs. Senate Bill 889 that passed in 2019 will move us in the direction from having just targets for cost containment or annual cost growth in public programs like we have today to one that's really statewide and a more equitable approach of really holding all markets accountable for a 3.4% cost growth target. We're in the process of launching that body of work, and we've had a large stakeholder group over the last year and a half that's been helping us design that program. One of the areas of work that group tackled was really what are the things we need to be doing as a state to really set ourselves up for the best chance of success. What are the things we most need to be doing to try to get our arms around cost? And they really zeroed in on value-based payment and payment reform being sort of the most critical thing. There's a lot of things we could do, but folks really felt like if we don't really make this aggressive switch from fee-for-service to value-based payment, and we continue to pay the healthcare system based off of how many things it produces instead of the value and outcomes that it's producing, that's sort of our biggest risk to be able to get our arms around cost. So out of that came a number of principles around setting some targets to move more aggressively to value-based payment. Frankly, the PEB and OEB boards and Medicaid program have already been moving in this direction, and so the idea is really to create some alignment across markets so that both across public and private markets, we're kind of all trying to move in the same direction of moving from a fee-for-service system to value-based payment. This is not an issue that's unique to OEB or PEB or Medicaid. It's an issue that's really fundamental within the healthcare system and finding new ways to pay in a way that helps us reduce costs. So out of that came this idea of asking OHA to convene, virtually convene, since we can't actually convene folks, major payers and providers in the state, and try to get a commitment to these principles, as well as to stand up a collaborative work group that would be sort of the home for really problem solving on value-based payment issues over the next couple of years. Again, we expect the issues that come up on how to pay differently are not going to be unique necessarily to one market. There might be some things that are unique, but largely they're going to be probably some bigger obstacles. So trying to find a mix of providers and payers that could be around a table where they could be really problem solving and trying to figure out how to meet these targets over the next couple of years together. So that's what we've been up to for the last couple of months. We'd asked both boards for approval to sign the compact and move in this direction. Since then, I'm really excited to report back that we have definitely gotten a large swath of the market to sign on over the last couple of weeks. We've gotten commitments from all of the large commercial insurers, most of the Medicaid CCOs, the Hospital Association, Medical Association, several large clinics. I think Rose sent out the list to you today, but right now, looking at this, we expect that we've gotten commitments that represent about 76% of the insured market. So that was really the purpose of this, was to try to move from a place of talking about value-based payment to a place where we've got commitments from the largest payer provider organizations in the state, and we're going to keep adding to that list. So our ask today is to see if OEB will ratify signing back on, and like I said, you can see the full list. We've gotten several large CCOs, but Kaiser, Moda, Cambia, Pacific Source, and the commercial market have all committed. The largest hospitals have committed. The hospital associations committed. So this is pretty exciting. We actually think this is probably the largest commitment that any state has gotten to really aggressively move towards value-based payment. And we're pretty excited, and we'll be hopefully announcing this more publicly in the next couple weeks.
Jeremy,
Any questions?
Jeremy, you probably had some abstains, but has any organization just flat out said no?
No, we have not gotten, we've gotten several folks that have committed, and we're still waiting for them to actually get their paperwork in. Moda is on that list. They've said they're definitely in, but the signatures have been trailing in the ice storm last week, kind of threw things off a bit. But no, I haven't had anybody just flat out say no. Our approach here has been to get the largest payers and providers on board, and then we're kind of going out to kind of large clinics and mid-sized clinics, and we'll keep branching out from there.
Great, thank you. Questions?
This is JJ. I think this is clearly in line with our efforts to mirror what CCOs have been doing in our coordinated care structure. So I have no issue with signing off on this.
Do you want a motion to approve?
If we're done with discussion. So go ahead.
I move to approve the Oregon Value-Based Payment Compact.
I second.
Second. All in favor, please raise your hand. Okay. Thank you. Is there anybody opposed? Doesn't appear to be. Jeremy, you have our wholehearted approval.
Great, thank you very much. This is really exciting. And then, as I mentioned, there'll be a work group getting off the board, and there's going to be a Pevin OEB seat if anybody is so interested in getting really in the weeds on value-based payment. So doesn't need to be decided today, but we'll just plant that seed, and Jeff, maybe work with you to figure out how you guys want to approach that.
Great, thank you. Appreciate you coming today.
Yeah, you bet. Thanks a lot. Take care.
Okay, a couple more things on our agenda. One is the Innovation Work Group update. JJ, do you want to do color commentary on my report?
Sure.
Okay, there were two major subjects at the last meeting on the 16th. It was postponed a week because of our snow ice challenges. One is furthering the discussion on centers of excellence and the results of the request for information that was conducted by Willis Towers Watson. The group is recommending to the boards that we pursue a homegrown version of this to develop standards and to first look at opportunities in Oregon, starting with musculoskeletal conditions. And so we're expected to go forward with developing that program and then bringing that to the boards. JJ, you want to add to that in any way?
Yeah, I think the primary catalyst for centers of excellence is cost savings in two avenues. Ultimately, the challenge we have as a board is we got hit 3.4%, and a common way that we've done that in the last 10 years is reducing benefits, and we don't really want to continue to reduce benefits to hit that number. So we have to find ways to reduce costs, and the centers of excellence will do that in two fashions. One, it will funnel folks for specific conditions into facilities that are not overcharging, and then a primary benefit both to the member and to the cost is that they have a much lower rate of complications. So best practice is like a 1% complication rate. OEB is currently at 3 to 5%, which is still better than industry standard, but not at best practice. So that would subtly reduce the complication rates, which lowers the costs. So you get better care and less likelihood of having problems with the procedures. The downside is you're going to force people to get out of their area. If they live in a place that isn't at a center of excellence, we're going to say, sorry, you have to go somewhere else to get that done, and we'll give you a way to get there and pay for it. But it's going to save the agency quite a bit of money potentially, depending on how it rolls out.
So one benefit of the approach that we're taking is that if we hired an outside vendor, we would immediately be implementing their select centers of excellence, and that could be Washington, California, whatever. Developing this process helps raise the bar in Oregon and keeps potentially avoids some long distance travel, and so there's a larger benefit than to just OEB.
And Jeff, in terms of what is available in Oregon, except for some very unusual situations like childhood heart transplants, we pretty much have the services that are needed within the state. So it really is one where it's not unreasonable for us to be able to, except for those rare, extraordinary events, to be able to come up with a thoughtful system of care.
So the consultant, one of the things is to develop a consistent benchmark measures for quality, et cetera. So we're using the same one across the system. And I think actually you had brought that up a while back, Tom, of making sure we had credible measures. And so we'll be working to approve that. And we're starting with musculoskeletal, which is our biggest issue.
Jeff, this bill.
Yeah.
Is part of this policy covered travel policies and guidelines, especially around families, if there's a minor involved?
That is
or single parent family.
That is to be developed. So that would be part of the overall design that we'd be bringing forth. And this is proposed to be at least presented for consideration to both boards.
Hopefully next month we'll bring this to the OEB board, at least for initial discussions. But the travel benefits, that's one that's going to need some exploration, because you want to make it generous enough to really not make it a hardship on the member's part.
Yeah, I'm just extending that conversation to families and specific situations.
Yeah, absolutely.
So the second issue is coming up on the next contracting year. There is an internal task force that's put together to recommend more consistent performance guarantees between PEB and OEB for contracting purposes. And so there are performance guarantees in the administration, but more importantly, there are clinical performance guarantees to be defined. And that just brings a little more clout to the marketplace.
Is that stepping into the value-based payment? Is that stepping into the value-based payment arena by doing that?
Not yet, is my understanding, Ali.
Yeah, these are more related to the clinical measures and administrative performance measures, and they have fees at risk and that kind of thing. It's definitely a way to incentivize quality.
So I'm just guessing that the finding the provider that meets these qualifications, or the hospital that meets these qualifications within the metro, there probably isn't much of a problem. If this one doesn't, then somebody else does. Where this is most likely a problem is in our more remote areas of the state. Would that be right? Have we done anything to have conversation with those communities? Those are the communities that are most wary of OEB to begin with. And now if we limit access for some really critical things where it could be perceived that critical family members might not have access to someone that was hospitalized. I just think there ought to be a voice allowed for those folks.
Agreed.
Yeah, I think when we look at the variation on some of these procedures, and I think the board has looked at this in the last year, you know, a difference between $15,000 for a hip replacement versus, you know, 40, 50, 60 and above for the same exact procedure. Those are the kinds of things that we're hoping to account for. So I think we're a long ways from bringing a recommendation as far as a travel benefit and that kind of thing, but that's going to be the key to making this successful, making people okay and want to travel to get the best quality service that they can and make it worth their time.
Is there any danger that some of the remote services might disappear from those remote regions because of lack of resource coming in?
Yes, that's always a concern for sure. It's something to consider.
Again, I just think we need to make sure that the people that could be most affected have a voice.
Yeah,
I appreciate that, Bob. I think the leading, if we take the triple aim as a paradigm, the leading area is quality. And if you've got recidivism rates or complication rates that are 8% as opposed to a center of excellence where it's 1, we really want to steer people to having the best outcomes so that they're not having to go back in the hospital and deal with infections and that sort of thing. So
the struggle is that you can't have it both ways.
Yeah.
You can't have as medicine has become more and more complex, and you need it's not the skill of the surgeon by herself. It is the team that you're able to amass and the sophisticated equipment, and you can't do it in certain settings. And we have to figure it out. We have to listen to the voice of all Oregonians as we go through this. But you can't have it. You just can't have it both ways. That's the complexity of it.
Yeah, a lot of the smaller facilities can't afford to offer the services with inequality. So, anyway, this is a measured, deliberative process. Not asking you to approve it yet. I take to heart your comments, Bob, and others. And you know, we're charging our consultants to move forward and helping us to define what a program would be like. Okay.
Yeah, I'll just add one last thing that you know, as we tighten the screws on all the ways that we could deliver healthcare in a more efficient way, in a more cost-effective way, the easy ones are gone. So we're left with the tough choices, and the answers are that the decisions we make they're not easy, and there's some people that are not going to like it. And so it's important that, to Bob's state, we give people feedback and that we're transparent with our decision making and processes, because there will be unhappy folks no matter what we do, because we got to find a way to deliver healthcare in both the cheapest way, but also with the best outcomes.
I think most of the savings proposed are derived from lack of complications.
Yeah.
So we're avoiding costs, unnecessary costs, not so much that we're going to the cheapest surgeon.
Yeah.
It's really an efficiency and quality. Let's segue over to the CIAO report in.
So CIAO's met for 3 hours this morning, and you've heard already a lot of what we discussed, and I appreciate the board's acceptance of moving forward with the recommendations around the Moda 360 enhancements. We really think that there's some very important elements that the board should see, and we are going to have a deeper dive for the entire board once we get through the renewal process. So in June, we'll talk more about the medical dental integration, chronic kidney disease, virtual physical therapy, advanced imaging steerage, and then a whole other area of this coordinated specialty programs where they're basically dealing with young people, children and adolescents in mental health crises. Shifting gears now, we had an update on COVID-19, and I found the most interesting numbers that we heard was, while in the United States there have been 85 cases per 1,000 in the population, OEB is 15.5. So the good news is so much of what we've done over this past year, including things that happened at the state level, at the schools and the other entities, has resulted in substantial risk reduction for our population. We then looked at what's happening so far with costs, and